Welcome. This is Sophia Asan of the Reproductive Health Supplies Coalition. So glad that you could join us today for this webinar being hosted by the Coalition's Market Development Approaches Working Group, or MDA Working Group. This webinar is titled Improving Access to Reproductive Health Commodities, the Role of the Private Sector. As a couple of housekeeping notes, please keep yourselves muted until you are speaking to the full group. There will be opportunity at the end of the webinar for dialogue, and we look forward to hearing from you then. In the meantime, throughout the presentation, feel free to enter questions or comments in the chat, and they will be addressed as time allows at the final portion of the webinar. So today we are really pleased to have the Access to Medicine Foundation joining us. And this webinar is going to discuss findings from the 2022 Access to Medicine Index for SRHR commodities and offer recommendations about what more the private sector may do to improve access. Our presenters today are Margot Warren and Anne-Charlotte Adouar of the Access to Medicine Foundation. Margot Warren is head of policy for the foundation. She liaises with governments, private foundations, and multilateral organizations that actively work to improve global health and access to medicine, in order to share the foundation's research findings and to identify key opportunities for collaboration and change making. Margot also manages the foundation's fundraising activities. And Charlotte is a government engagement and policy officer with the foundation. She supports their ongoing conversations with governments, private foundations, and multilateral organizations in order to share research findings and identify key opportunities for collaboration and change making. We're very pleased to be joined by both of them today, and I'll now turn it over to Anne-Charlotte.
Thank you so much, Sophia. And thank you to the Coalition for having us today. I'm very pleased to be presenting the findings, and later in the presentation, I'll be handing it to Margot for some discussions. So today, as you mentioned, we'll be presenting the SRHR findings from our 2022 report. So first of all, I assume that quite a few of you might not know us, so I'll give a little bit of an overview of who the Access to Medicine Foundation is and how do we work. So the Access to Medicine Foundation is a nonprofit organization that aims to guide and incentivize pharmaceutical companies to do more for people living in low and middle income countries. We are fully independent from the private sector. We don't receive any funding from them. We are funded by the Dutch and UK government, as well as the Bill and Melinda Gates Foundation, the Helmsley Charitable Trust, and AXA Investment Managers. One of our most famous research program is on the index. In the index, I'll explain it a little bit in more detail in some slides, but we rank 20 of the world's largest pharmaceutical companies and evaluate their impact on improving access to medicine in low and middle income countries. We also have other streams of work, for instance, on AMR. So obviously we publish reports, but we really don't want them to just sit on the shelf and have no one use them. For us, it's really important to get the work started as soon as they are published. So we're very happy to see broad media coverage. It's a great way for us to raise public awareness, to see our findings featured in television, radio, or newspapers. It's also a great opportunity for companies to be rewarded when they have been doing better, and also a good incentive for lower performing companies to want to do better in the next index. And we also see that companies really do care For instance, this year, many CEOs and directors of companies have been posting and tweeting about their ranking on their social media. So the company aims to drive change. The foundation aims to drive change in companies' actions by engaging through different angles. And so we work collaboratively so that companies hear a joint message from all different stakeholders. The first group that we engage with is global health stakeholders, such as governments or NGOs or international organizations. So we work very closely with our funders, but also other stakeholders. And we focus on collaborating and identifying synergies to encourage further actions from companies. We draft special reports, blogs, and articles to highlight key topics using our data as evidence. And we speak at events. We also host events to share these findings and disseminate to really have impact. And we also share it through social media. We also engage with investors, with over 130 investors managing assets over $21 trillion US. Investors have really an essential part in access to medicine, as they can really incentivize companies to do better. We find that companies listen a lot when a request comes from investors, as they actually own shares in the companies that we are monitoring. So when we discuss with investors and request them to maybe discuss certain topics with companies, they really listen. We provide briefings, information before bilateral meetings, and also, again, data as evidence to make their decisions. Finally, we engage very closely with companies. So our company engagement team is in constant connection with them. We also organize events, workshops with them where they can share lessons learned and also best practices. We find that the publication time is a critical moment to have further action. So we share detailed report cards with all the 20 companies in our scope of the index, and our CEO, Jay Iyer, has CEO calls following the publication. That allows us to really deep dive into the finding and let them know what they can do more. And we find that many companies are very engaged. So in a nutshell, this is our framework to have some change making. We obviously try to drive action through our report that can directly influence the industry, but we also want to catalyze all different stakeholders, so global health organizations, governments, investors, and the public, to see the industry improve on access. Let's look at the scope of the 2022 index. First of all, for the company scope, we're looking at 20 of the largest pharmaceutical companies based on a combination of market capitalization and relevance of the pipeline and portfolio for access to medicine. For the geographic scope, it's 108 low and middle income countries. That's based on World Bank data and UNDP data. For disease scope, we have 83 diseases, conditions, and pathogens. That includes 10 maternal and neonatal health conditions. That also includes 3 diseases that exclusively affect women and girls linked to biological sex. Those are endometriosis, ovarian, and uterine cancer. And that inclusion in the disease scope increases the capacity of the index to assess the unmet needs of women and girls living in LMICs for sex-linked diseases. And finally, for product type scope, we're not only looking at medicines and vaccines, we're looking also at contraceptive methods and devices, vector controls, diagnostics. Let's look at the analytical framework. The index has been reporting on companies' actions for over 15 years. And to evaluate them, we've carried out very thorough consultations with global health experts. And following these conversations and consultations, 3 technical areas were created and slightly weighted differently. And within each area, you'll find indicators. So the 3 technical areas are governance of access, research and development, and product delivery. Under each technical area, you find priority topics, and under each priority topics, indicators that we use to assess companies' actions. We're currently in the process of consulting new stakeholders for the new next methodology. So we're really happy to hear your thoughts today and use this moment as a consultation opportunity and hear if you think there are ways to improve further our methodology and how we look at our findings. So today I'll be driving you through all the different findings from the SRHR report. And then I'll hand it to Margot to ask you some very targeted questions. So we'd really value your input and your expertise. So feel free to share your thoughts. Let's look at what is in the index. First, you have 3 key findings. Then it's followed by three chapters deep diving in the technical areas. You also have 20 detailed company report cards, 19 best practices, and 3 special reports. The special reports are on COVID. Another one is on longitudinal analysis of companies' progress. And the last one is on SRHR, and that's the one I'll be presenting today. But if you're interested in any of the other findings, please feel free to go to our website, accestomedicinefoundation.org, and you'll find everything relevant. So let's actually dive into the report. So the special report examines the extent to which companies are conducting research on new product and formulations for SRHR-related health needs that have the potential to overcome barriers to access in LMICs. And for marketed products, the index assesses what strategies companies are applying to LMICs to address barriers through mechanisms like registration and access strategies. So this chapter also includes a report of company capacity building efforts and engagement in inclusive business models that reach women and girls living in LMIC. I'll give an overview of the results. Again, if you want to have a deeper dive, the report is available on our website. Let's dive into the R&D pipeline. There is a total of 171 projects in the pipeline that target SRHR-related diseases and health needs in the scope of our index. You can see that cancers are a well-addressed category within this SRHR diseases and needs, with 60% of the pipeline targeting at least one cancer. So that's 105 projects. If we look at the R&D pipeline of the overall index, not only looking at SRHR, it actually mirrors the findings. So we find that NCDs that also impact people in high-income countries receive more attention in R&D. And however, we find that having a project in the pipelines does not actually mean that it will end up being affordable and accessible in low and middle income countries. If you look at the bottom left of this slide, you can also notice that 5 diseases and conditions are not addressed at all by any R&D projects. Still looking at R&D, we notice that companies are addressing 7 diseases with priority gaps. Just to make sure that everyone has the same definition in mind, an R&D product gap exists when there is an urgent need but low commercial incentive to engage in R&D for products to sufficiently treat, diagnose, or prevent a disease or condition. An example could be, for SRHR, HPV diagnostics and treatments for postpartum hemorrhage. In total of the 171 projects that are related to SRHR, we see that 56 are a priority gap. We're using the list of PolicyCure to define those. And within these 56 projects, a majority look at HIV and AIDS and hepatitis B, and a handful at other diseases such as gonorrhea or chlamydia. You can also notice that some diseases are missing, mainly herpes, preeclampsia, syphilis, and contraceptives. Currently, there are only 8 companies that are included in the index that are conducting R&D for gaps in any of these therapeutic areas. And these companies are AbbVie, Daiichi, Gilead, GSK, Johnson & Johnson, MSD, Roche, and Sanofi. Moving on to registration. the overall finding is that registration is lacking, especially in low-income countries. So on this map, you can see that the darker the blue is, the higher the number of registration filings there is in a specific country. So there are more registrations in Mexico, Brazil, China, for instance. Registration is a key first step in ensuring products can reach the market in a specific country. When companies do not register their products in certain countries, women can be left without access to these products. But registration does not mean availability, and companies may not be able to sell their products in these countries if there is no capacity to treat people locally or mechanisms to purchase. So overall, we see that many SRHR-related products are not wildly filed for registration at LMICs. You can see that on the map. Many countries have a very light blue. We are looking at the most recently launched products. So we look at the 10 most recently launched products for each companies, and we see where they have filed dossiers. In general, we find that older products are more widely registered in LMICs. For instance, the most filed product within the SRHR-related scope of the index is a product from Bayer. It's an IUD, and it has been registered in a total of 64 countries. There are a few good examples for newer products. For instance, a breast cancer-related product from Roche that was approved by the US FDA in 2019, and it has been filed for registration in 58 countries within the scope of the index. In general, we see that most products are filed for registration in upper middle income countries. When we look at all these products, it's 80% of them that are registered in at least one of them. So 60% of these products are also filed in at least one lower middle income countries, but we find that low income countries are overlooked, with only 46% of them having at least one product that is registered there. So we are looking at 39 products. 18 of them are filed for registration in low-income countries, but only 7 of these products are filed in more than one low-income countries. So a very, very low number. We find that registration is lacking, but there are some positive exceptions for some medicine on the essential medicine list. So among the product and scope of this analysis, 8 are on the WHO EML. And this list is a list of medicines considered to be most effective and safe to meet the most important needs in a health system. So this figure that you see on the slide shows the number of the 108 LMICs in which there are filed for registration, and it's broken down by whether the filing is in a low, lower middle, or upper middle income countries. So the low income countries are the darkest color. I want to note that MSD is a non-submitting company, so no data about filing for their relevant products were submitted by MSD, and no evidence was found on the public domain. We see that Bayer's IUD is quite well registered, with especially 10 in low-income countries. And we also see that HIV/AIDS products are rather well registered, with however still a low number in low-income countries. You can also notice that for cancers, the registrations are very low, and especially almost non-existent in low-income countries. So despite some good examples, again, it is very much lacking, despite these products being on this list. Moving on to supranational agreements. Supranational agreements are, for instance, agreements for pool procurements with Gavi or the UNFPA. These can be really helpful in driving down the price of medicine and improving access, especially in countries with a limited health budget. There is a total of 39 products supranationally procured if you look at the whole index. Within these 39 products, 17 are SRHR products. And within them, only 3 SRHR health needs are covered. These are HPV, contraceptives, and HIV/AIDS. So while bilateral donors are the dominant source of funding in global health more broadly, providing 52 actually of the overall development assistance in health, they're quite absent actually from the field of NCDs. So more agreements are very much needed. On this slide, you can see that the total number of companies engaged in supranational procurements goes up to 8. These companies are AbbVie, Bayer, Bristol Myers Squibb, Pfizer, GSK, MSD, Roche, and J&J. And you can see how many companies are engaging with each procurement agencies. For instance, 5 companies are engaging with the Global Fund, 3 companies are engaging with the UNFPA. If you remember the last slide, all of these supranational procurement agreements are focusing on HPV, vaccine, and contraceptives and HIV products. Usually, the partners are most involved in cervical cancer vaccines are Gavi and UNICEF. For contraceptive methods, it's mainly UNFPA. And for HIV, it is all actors are involved, but the Global Fund has the largest amount of products. Some good examples of collaborations would be, for instance, Pfizer that has an agreement on contraceptives with FP 2030, or Bayer that has an agreement with the UNFPA also on contraceptives. Moving on to capacity building. There is a total of 39 capacity building initiatives. Within these initiatives, 19 are on health system strengthening, 5 on supply chain, 5 on manufacturing, and 10 on R&D. Interestingly, you can notice that the initiatives tend to target specific regions. So for instance, for manufacturing capacity building, we have seen in our data that it is mostly in India, China, and Brazil. And it's also mostly focusing on HIV products, beside a few examples. For supply chain capacity building, it's mostly in sub-Saharan Africa, with an emphasis on Ghana, Nigeria, and Malawi. And for R&D capacity building, it's also mostly in sub-Saharan Africa, with some exceptions in China, India, and Vietnam. And for health system strengthening, it's actually spread across countries, but most active initiatives are in Kenya, India, Uganda, Vietnam, Ghana, and the Philippines. Some best practices for capacity building have been highlighted in this iteration of the index. You see, for instance, a best practice for Roche for an initiative called NJIA. It's a leadership and development program in Tanzania aimed at raising awareness of cervical cancer. And another good example is Bayer, that is one of the 3 suppliers of implants and oral contraceptives for the Reproductive Health Supply Coalition and the Global Family Planning Visibility and Analytics Network, and they participated in shaping the platform. So now, taking in consideration all the findings that we've covered, what can be done to improve access to SRHR products in low and middle income countries? First of all, there should be a tailoring of access strategies for more products in all income groups. Second, there should be more investing in R&D for product gaps relevant to women and girls in LMICs. You should also engage in supranational procurement and addressing gaps for NCDs. We should also see an increase of the breadth of registration filing, especially in low-income countries. And finally, we should be working in partnership to build capacity and strengthen health systems. I'll give you a very brief overview now of the index ranking. In this iteration of the index, we see that 4 companies are really at the top, performing really quite well. So GSK is in the first position. It tops the overall ranking and the R&D sub-ranking. The second company went up one position from the last iteration of the index. It's Johnson & Johnson. It demonstrates strong performance in all three technical areas. The third company went up from the seventh position. It's AstraZeneca, and it is ranking #1 in product delivery technical area. And finally, Novartis, #4. It performs well in R&D access planning and equitable access strategies. Also, I want to caveat that the index looks at 83 diseases, conditions, and pathogens, and at entire companies' portfolios and projects across 31 indicators. So one project on one disease is typically not enough to impact the overall performance. For instance, a project on COVID. And another company to notice would, for instance, be Bayer, who's a very strong riser this year, went up from the 13th position to the 9th. So joining the top 10, it is incredibly difficult for companies to move to the top 10 and also move within the top 5. There's a very, very strong competition, and you can see that companies are really close in scoring. So Bayer managed to join the top 10, and it's improved its performance in R&D, and the company demonstrated best practice for the broad geographic reach of its R&D access plans. So these were the findings. I'm curious to hear about your questions and comments on them. We're going to move on to a section with targeted questions about our methodology review. So your question might be answered at this time as well. So I'll hand it to Margot, and feel free to comment on her questions and ask any other questions.
Can you go to the next one? Yes. Hi, everyone. Thanks very much for joining. We're very excited to have such a diverse group and such a big group. So thank you very much for taking the time and joining today. As Anne-Charlotte mentioned, we are in the process now of actually revisiting the methodology. We do this on a 2-year basis. So we publish an index, and then we go back and look at the methodology we use to actually publish that particular index. And the reason we do that is because we want to always be raising the bar. We want to always be making sure that our indicators are fit for purpose, that they're still the most relevant areas of access, and that the way that we're analyzing information is both fair to the industry, but also meeting the expectations of the global health community. So in previous years, we've done consultations with over 100 stakeholders, really making sure that we're hearing sort of the different perspectives and the different ideas around the Access to Medicine Index and how we actually are evaluating these companies. We feel it's important both for buy-in from the companies to ensure that they are willing to hold themselves to this account, but also, again, that the rest of the global health community is also in alignment and that we can sort of come up with this consensus of what the expectations truly are for the pharmaceutical industry. We have presented previously on some of these findings. I think some people may be aware, but I'm very curious to hear kind of your general feedback on some of the findings that Anne-Charlotte presented, and as well on these specific questions. We've gone back to our research team and really asked, what are your burning questions that you'd love to hear from this group? We know it's a very specialized group with lots of experts and rich expertise across the board. So very curious to hear your opinions on some of these questions. I see some comments already coming in the chat. So maybe we'll take a look at those, and I'll pose one to the group right now and see if there's any initial comments specifically related to registration and the way that we look at whether companies are filing to register a particular product in a particular country. So one thing that we've been discussing quite significantly in these stakeholder consultations is thinking about what is the true responsibility of the pharmaceutical companies in scope to file a dossier. We're very specific that we're not looking at whether a product has been approved by a regulatory health authority, as we see that being the responsibility of the regulatory health authority, but rather has the company actually put forward a dossier to file that product, because that we very much feel is the responsibility of the company. And we've heard a lot of different interesting conversations around collaborative registration procedures, potentially using a proxy country in a region as a useful mechanism to expand throughout a geographical area, and thinking sort of about different mechanisms that may be at play and how to accurately capture those when we think about registration. So I'd be curious to hear from the group if there are any specific comments on registration. You can feel free to either take yourself off mute or raise your hand function in the Zoom.
Hello, can you hear me?
Hi, yes, we can. Thank you.
Yes, this is Oleg Zhurov of Ferrin Pharmaceuticals. That I was just putting a comment that we're committed to register in all the low and low middle income countries, and we currently have the registrations in 13 for the heat stable carbetocin for the prevention of PPH. I would like to say that this, the regulatory barrier is a very significant barrier, because we are using to the extent possible the collaborative procedures. We used the stringent regulatory authority Swissmedic registration as a start. Then we used the marketing authorization for global health products for 10 countries within in Africa, which was run by Swissmedic. We got 8 registrations. 2 countries are still outstanding, and the predictability was very low. Some countries, some authorities registered within 3 months. Some others were taking more than 2 years, and the challenges remain around the harmonization of the label, of the packaging, and so on, because we're trying to use harmonized packs for the vast majority of the countries to reduce cost and increase flexibility. We also we achieved the WHO pre-qualification in July, and we're looking at using the CRP procedure as well. But so far, there are some challenges with that. We are using WHO SRA CRP, which is relying again on Swissmedic, and again despite the fact that it's harmonized procedure, we see a lot of challenges with the local regulatory requirements, not only the translations, but the kind of in terms of the additional documents which are required by the authorities about the specific requirements in terms of the samples, like for what purpose, and some of the post registration requirements. So what I'm trying to say is just it's not only the willingness of the companies to prepare the dossier, but the procedures are requiring, in vast majority of cases, they require a local agency present on the ground to handle the local registration. So it's a quite a significant resource, time, and money commitment from a company to try and attempt the registration in many of the low and low middle income countries. We're doing that within a kind of broader collaboration, and it's an ESG commitment from Ferrin, but I can fully understand that it's for a company which is like a for-profit organization to entertain that type of a commitment. That's a very, very, very tall ask. So it's not obvious that it would be easy to do, and we see little convergence actually, even with the 2 WHO procedures are not fully aligned between themselves. So yeah, regulatory one of the first barriers for entry, and it's a significant commitment, and not all obstacles are easy to overcome. Thank you.
Yeah, thank you very much for those comments. Super useful and definitely interesting to hear your insights and thoughts. Maybe if I could ask one follow-up question to you and open it up to the wider group as well. One of the things that we look at when we're analyzing data for registration is thinking about the burden of disease for other products in scope of index, where you can very clearly and easily look at the DALY burden. For contraceptives, we have to sort of use a different methodology. So curious, when you're thinking about how to prioritize specific products in specific countries, are there different factors that you look at? How are you thinking about which countries you would roll out a new product in first?
Well, if it's a question to me, Margaret, then it's a bit difficult because currently I'm working on a specific project, which is this the project Save Both, like to bring heat stable carbitol into this 88 countries. It's kind of a small group of us, and we're working full time. Like at the time when I was responsible for the portfolio analysis in the company, in some of the previous roles, we looked at the prioritization of the development work, which would inform either the FDA or European agency or like Chinese or Japanese, and that would also inform the feasibility of those studies would also inform the sequence. That was 10 years ago. We would not necessarily look at the onset at low and middle income countries. They would be extensions of the US or European program, which would allow to get access to those countries. However, Ferrin was always trying to file for registrations in as many countries as possible, even if the access components were not always easy to overcome. So we have a number of products with registrations in many countries where it was not possible to launch for commercial reasons. So just because the launch is actually not only, it doesn't generate your revenue right away, just like there's quite a lot of work on the ground. And that's not always a given. How do you overcome the barriers for access? And low middle income countries, to include that into the registry, into the guidelines, into the formularies, and just in secure procurement, that's not easy to overcome. So that would be mostly kind of the feasibility considerations would be driving those decisions.
Yeah, thank you. Very interesting. And yeah, thanks for that additional information. Is there anyone else who would like to make a comment on registration or an inquiry or anything that they would like to add to Oleg's comments? No? Okay. Then I think we can take a couple of questions from the chat, because I think they also relate to some of these questions. So one was about whether we have been participating in the RHSC. So the answer is yes. We haven't been included in a specific work stream, but we're very interested to explore that. And thinking about some of the overlapping priorities, I think there definitely are many. As Anne-Charlotte mentioned, there's quite a few different diseases and conditions that are included in our scope, specifically for SRHR commodities. I know that the company scope is a little bit different in that we're specifically looking at the 20 largest R&D based companies, and this group is much wider than that. But ultimately, I think there are a lot of learnings that can be shared across the board. Companies don't necessarily need to be in scope of our research in particular to sort of understand some of the access challenges and unpack them and think about what they can be doing to improve access to medicine to these reproductive health commodities. I see there's another comment about ESG initiatives. So Anne-Charlotte touched on it briefly at the beginning of the presentation, but we do quite a significant amount of work with investors, and those investors tend to be those focusing on ESG. However, we've also gained in recent years a lot of traction from some of the more mainstream investors as well. And those investors have sort of direct shares within the pharmaceutical companies that we look at. And we find that more and more these investors are able to really highlight critical issues of access and bring those to the companies that they have shares in, and sort of think critically about what more those companies can be doing. We find this to be an incredibly powerful element of our research. To give you an example, and Charlotte showed you the ranking for the Access to Medicine Index in an earlier slide. And she mentioned that near the top, the competition is really stiff and it's very difficult to move up. And you have to really be putting in quite a significant amount of work to stay at the top, but also to move up even within the top 10. But we've also heard from our investors that there are specific examples where companies sort of are less engaged. Maybe they're near the bottom of the index, but they still feel compelled to improve their performance because they know that investors are watching and investors are questioning them and want them to be engaged and want them to participate fully and be transparent with their information and their data. So this is a highly motivating factor for them when there are these sort of questions being asked directly by their shareholders. So we're certainly seeing some trends in the ESG movement and in a very positive way that is, I think, definitely encouraging companies in that very direct sense to improve their performance. And they're hearing the message loudly and clearly from those investors. Are there any other questions before we move on to some of the other points that we've highlighted for feedback? Okay. One of the other areas that we look at in the index and in a variety of different indicators is the ability to improve local manufacturing, and specifically through technology transfer. So we have some interesting cases that we highlight within the index and within the SRHR special report that's included within the index. And we'd love to hear more about sort of the feasibility of improving local or regional availability, specifically of SRHR related products. I think when we come to the conversation around sort of local manufacturing and technology transfers, SRHR products are not always sort of the front and center of those discussions. So we feel it would be a really interesting piece of feedback to hear from this group on what the thoughts are in terms of improving local manufacturing, whether it be mechanisms to do that, what is most feasible, sort of what are the interesting approaches out there. Again, we've highlighted some of them in the context of our work, but we'd love to hear from you folks if there's anything else you'd like to add as we move forward with the next iteration of the index. Any comments, any points of interest that you'd like to highlight?
Hey, Margot. Hi, this is Maggie Kilborn-Brook from PATH in Seattle, Washington. Donors have long been interested in the idea of local production, ideally to bring down product costs, but it doesn't always work out in the long run. And there are some interesting examples of technology transfer and local production efforts that weren't successful. And so I think it's sometimes interesting to look at those. And the USAID funded Matrix project, which is a 5-year-long project to advance the next generation of HIV prevention and multi-purpose prevention technologies. They have a working group that is devoted to developing the business case for HIV prevention products and MPT products. And one of the things that they've done, there's a lot of interest in looking at the feasibility of local production for these next generation of HIV products that are currently in development. And they recently had a webinar looking at some of the opportunities and challenges based upon other sexual and reproductive health products of local production. So we can help you get in contact with those folks. They might have some interesting contacts and insights to share.
That would be wonderful. Thank you, Maggie. That sounds great. And certainly some good points raised there. I think it's interesting for us to be able to explore what has gone well, sort of best practices that we can sort of point different companies to, but also to look at sort of what didn't go so well and why, and what were the factors behind that, and how can we sort of prevent that negative scenario from unfolding in the future. And again, sort of looking at what is the role explicitly of the companies in the scope of our research to facilitate that local manufacturing. So that's a very interesting point, and we would love to get in touch with those folks as well.
Sure.
I see another question in the chat about examples of innovative access models that the private sector is interested in. So for example, the Population Council and Bayer set up the International Contraceptive Access Foundation. And over the past 20 years, this initiative has not only advocated for the hormonal IUD, but also improved access in LMICs. Do you see such innovations occurring, and what does it take for them to occur? I think it's a great question, and I think it relates also to another comment about sort of the role of partnerships and how partnerships can be really influential, particularly for R&D, and to advance some of those priority gaps that Anne-Charlotte spoke about. What we tend to find in the broader index is that when there are different access-oriented organizations, so maybe a product development partnership, or when a large R&D-based company is receiving funding from, say, Bill and Melinda Gates Foundation or the Wellcome Trust, we do tend to see that there's no coincidence access is significantly improved in terms of particularly access planning while projects are still in the pipeline. So companies tend to come to the table, of course, when there is sort of a collaborative opportunity, but also when they're developing new R&D projects for some of those priority gaps, they're already thinking about access much earlier on in the product development cycle. They're not waiting sort of until a product is already on the market for 10 years to then decide, okay, I'm going to make this available and affordable in some, maybe a handful of low or middle income countries. We tend to see that there's much more activity when things are done in collaboration. And we have some really interesting findings that we can share afterwards as well, that give you sort of the breakdown and the statistics behind what we're seeing. Ultimately, we do find that companies are interested in partnerships, that it can be a really good way to fill some of those priority gaps. And it's definitely sort of a collaborative procedure that needs to happen often in order to get those access strategies up to par, and to make sure that products are being developed for those priority areas, but that are also making sure that they reach those who are most in need. Any other questions about that point, or shall we move to the next question in our feedback session? We have about 10 minutes left, I'm aware. Okay, the next question we really wanted to pose to this group is, when we're thinking about those supranational procurement agreements, so maybe agreements through, say, Gavi or the Global Fund, we often ultimately in the index are looking at, okay, what are the terms? What are the most important elements of these agreements? We have a specific set of criteria that we look at, that we have looked at for many years, but we're also in the consultation period looking to make sure that those are still the right criteria, and that we're still looking at supranational procurement agreements in the right way. So for example, some of the things that we'd like to see is that there's a clear kind of strategy for measuring patient reach, that the terms of the supranational procurement agreements are also applicable to countries that may, say, have graduated from Gavi, that are not necessarily included in the scope, but that they're able to also benefit. So these tend to be sort of upper middle income countries that may be not the core focus of those specific procurement agreements, but we'd like to see ultimately companies making sure that they're still providing those same terms to countries that may be not included. So Curious to hear from the group if there are any specific elements that you think are most critical when it comes to these agreements. I know there's a lot of partners on the call who may have interesting insights. So would love to hear from the group if there are any specific factors that you think are most important to include in these agreements. If there's also any other representatives from companies on the call, would love to hear from you as well in terms of how you've been working with some of these different international partners and thinking about what sort of pooled procurement mechanisms have been beneficial, have sort of encouraged you to maybe market a product that you wouldn't have considered marketing otherwise, how they have been beneficial to you as a company, and how they have encouraged you to make products more available and affordable. Curious if there's any thoughts on that front as well. If folks have any additional comments that they want to share also via email, and Charlotte and I can pop our emails into the chat. Very happy to continue this conversation offline as well, to hear your insights if it's easier. I know it's a big group today, but this is the very beginning of our consultation period. So it's going to last ultimately until around May of this year. The sooner we receive the feedback, the better, because it helps us shape sort of the direction of the new methodology, but love to hear from you. Again, as Maggie suggested, if there are others you think we should reach out to, if there are specific experts that you think we should get in touch with, who may be able to add some interesting insights to some of these questions or others, very happy to stay connected and very happy to hear from you and to hear from others. You know, we have only about 5 minutes left, and I want to leave a little bit of time to wrap up. Just going to open the floor in case there are any questions on capacity building initiatives and thinking about the factors that companies and partners use to actually assess where their resources are best needed. This is something that we look at very closely in the context of the index. We have a very specific set of criteria that we look at when it comes to capacity building initiatives, but something that we hear from time to time, particularly for products that would pertain to specific cancers. We hear that there just aren't sort of the resources locally available or the capacity locally available to be able to offer a different additional treatment and to be able to really make sure that these patients are receiving proper and adequate care. This is something that we are able to highlight in the index when we do see that companies are offering some of these specific capacity building initiatives, say for health system strengthening, or even for supply chain strengthening, for R&D at the local level. So very curious as well if anyone on the call has specific expertise in capacity building, both from the company perspective as well as the partner perspective, to think about how they identify sort of where their resources would be most useful and best needed.
Hey, Margot. Hi, this is Maggie Kilborn-Brook again. I understand that in the scope of the activity that your group undertakes, you focus on these 20 largest pharmaceutical companies, but I think some of the questions that you're asking are things that some of the smaller companies and smaller organizations are doing. So, you know, maybe even when you're asking your questions, to open it up so that people understand that even if they can't reflect on the activities of these 20 largest companies, there's a lot of innovation going on around some of the things that you're talking about, but I'm not sure that it's to the extent which it's happening in some of these large portfolios.
Yeah, thank you for that comment. And certainly we would love to hear in general examples. I think as I mentioned, there's a ton we can learn from what other companies are doing as well, not just only those included in the scope. What we found as well in some of the other areas of our research is that there are definitely unique challenges for different sized companies, but ultimately we've seen some really good practices, for example, in AMR from small and medium-sized enterprises that are really quite small in comparison. I popped it in the chat as well. Even though this specific analysis and the Access to Medicine Index in particular is focused on large R&D-based companies, we have a whole research program now devoted to generic medicine manufacturers. And we're actually in the process of, we just launched the first ever framework to measure their efforts to improve access to medicine, and are now in the process of collecting data and looking at the core access activities of a initial sort of pilot group of 5 companies. But we certainly feel as a foundation that there's a huge role to play for healthcare companies across the board. And we do find that while there are some specific issues pertaining to specific companies, that there's a lot to learn from each other. And there's a lot of sort of interesting activities that can be replicated, whether it's a generic company or whether it's a large R&D based company or even a small and medium sized enterprise. So I think there's a lot of learnings, as you say, Maggie, even if it's not specific to large R&D based companies.
Also, Margot, this is Soumya.
Hi.
Hi, Xpop. I just put a note in the chat box that a lot of the efforts that you're talking about are funded oftentimes by bilateral donors to do a variety of activities. And so it's really about partnerships, the idea that you mentioned earlier, through which you can begin to talk about the extent to which a particular company gets a product to market to the sorts of population segments that as a group the RHSC is interested in serving. So it'll be very hard for any one group to do all these things. So it really is sources of funds to do a range of activities from all the way from the science to coming to the end user. Over and out. Thanks a lot for this great presentation.
Yeah, thank you very much for that comment. And absolutely, I would say in the context more broadly of the Access to Medicine Index and the larger sort of priority R&D that we look at across the board for all of those 83 diseases and conditions and pathogens that Anne-Charlotte mentioned, we find that about 50% actually of the projects for priority R&D are being done in collaboration with partners receiving public funding. So I think that in itself demonstrates that there's a huge influence when it comes to partnerships, when it comes to specifically R&D, but also, as you say, sort of throughout the value chain, there are a lot of really important partners for making sure products are available and affordable in these low and middle income countries. So definitely fully agree. There's a lot of really interesting partnerships, not only for R&D, but also throughout the value chain. I know we're at time, so I just want to thank everyone. Maybe pass it off to Sophia. It's been lovely being here. Thank you so much for your comments. Please do feel free to reach out. Anne-Charlotte popped our emails in the chat. We'd love to hear from you. We'd love to connect you with our research team to have a deeper dive into any of these specific questions or anything you saw today in terms of the findings. And we look forward to staying in touch.
Thank you very much, Margot and Anne-Charlotte. We appreciate your presenting the webinar today. And the recording will be shared with the MDA Working Group listserv later, and will also be stored on our website along with the slide deck. So thanks for joining us today, and have a great rest of your day.